Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. Today, we'll be discussing updates on flu, COVID, and pneumococcal immunizations. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Everyone has entered the meeting on mute, but we will have a discussion at the end of this webinar. So if you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. And we'll have lots of resources that we'll be sharing in the chat today. So please keep an eye on that if you would like to get any of the links that we'll be screen sharing. We encourage you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we'll be discussing the bivalent COVID-19 vaccine and stroke risk. So that will be Wednesday at 2 p.m. And I'd also like to invite everyone to a special webinar next Tuesday at 2 p.m. where Dr. Jean Storm will be presenting on navigating opioid prescribing through 4 different healthcare environments: outpatient, inpatient, long-term care, and hospice. That webinar will be eligible for continuing education credits. If you're interested in attending that webinar, I will be dropping the link in the chat shortly where you can find details and how to register. And again, that webinar will be Tuesday, January 31st at 2 p.m. And now I'd like to introduce our guests today, Deborah Wright and Christopher Henry. Deborah is a quality improvement specialist at Quality Insights. She joined our team after being in the long-term care industry for more than 30 years. She has a wealth of experience in long-term care nursing and management, ranging from certified nursing assistant to vice president of healthcare operations. She is most passionate when working with the MDS process and quality improvement. Christopher Henry is also a quality improvement specialist here at Quality Insights. He is a master's prepared nurse who has been in healthcare for over 30 years. He has served in various healthcare leadership roles, from assistant director of nursing, director of nursing, and as a nursing home administrator. He has worked in every component of healthcare, from hospital, home health, long-term care, and clinical care, including his most recent position as director of nursing and employee healthcare coordinator for a federally qualified healthcare center in West Virginia. So welcome, Christopher and Deborah. Deborah will have her camera off today, I believe, because she's having some lag issues, but I think we've got the sound problems resolved. So Deborah, if you're ready, I'm going to unmute you again, or you might have to unmute yourself, and you can go ahead and get us started.
All right, thank you, Kathy. Like Kathy said, I am having some technical difficulties here, so hopefully we can get through this without any trouble, and Kathy will let me know if you guys are hearing difficulties on your end. So we've chosen this topic today for 3 main reasons. The first is because we've seen lower than usual percentages with vaccination rates, especially related to the flu and pneumo, and we want to kind of talk about ways to combat that. Secondly is for those that are participating with the quality improvement strategies, there is a percentage of financial reimbursement for facilities that show improvement with their vaccination rates. And if you have questions on that, you would want to reach out to your managed MA providers. And lastly is because we've been seeing some confusion with what is considered up to date per the new pneumococcal guidance. So with that, we're going to start with the pneumococcal vaccination guidelines. Kathy, if you could please pull up the decision tree for me. This is something that we've kind of created to better help facilities in determining what's considered up to date. Let me see if I can see the whole thing.
Sorry, just a moment. Are you all seeing the right screen? Just wanted to make sure.
I'm seeing the right screen. Can you make it go down just a little bit that we can see the decision tree part of it? There, thank you. So if you were a facility pre-COVID, let's say, that was really on top of tracking your residents and their pneumococcal vaccines, and you were ensuring that your residents had both the pneumococcal 23 as well as the Prevnar 13, and you were ensuring that both of those was were being given at the correct spacing time. If your residents have both those vaccines, then they are up to date. You don't do anything else. Some things that we are seeing is that whether they've had both of these vaccines or not, some facilities are going through and giving every resident the Prevnar 20, and that you do not have to do. If you were keeping up with the Pneumo 23 and the Prevnar 13, and your residents had both of those at the timing that they were supposed to have them, they are considered up to date and you do not need to do anything else. Where the Prevnar 15 and the Prevnar 20 come into play is for your residents that did not have the Pneumo 23 and the Prevnar 13. So that's where you would look at the decision tree, and the first two lines are where you have the choice of starting at those two spots. Most people like to do the first one because it's a one and done. So if you have a resident been admitted, and for topic of conversation, we're going to assume that all of your residents are over 65. So you have a resident that's been admitted, they've had no history of the pneumococcal vaccine, then the recommendation is for them to have the Prevnar 20. Once they have that Prevnar 20, they are considered up to date and you're done. Your other option, if they have no history of pneumococcal vaccine, is to give the Prevnar 15, but then you would have to track them, and 12 months later, they would be due for the pneumonia 23. If you had a resident that came in and had a history of only the Pneumo 23, then you would track them, and at least 12 months later, they would get either the Prevnar 15 or the Prevnar 20, whatever the physician recommends. And then you would, if they've had the Prevnar 13, that's been their history, then you would follow like you've always followed, and at least 12 months later, then they would be due for the Pneumo 23 and they would be considered up to date. So that's the decision tree for the Prevnar vaccinations, the new guidelines that came out for the 15 and the 20. Does anyone have any questions regarding the pneumococcal vaccinations? At the end of this presentation, we are going to talk about MDS coding and how you would code that pneumococcal vaccine as being up to date.
So there's a question here in the chat. It says, what happens when the Pneumo HX includes a date, but not a non-specific Pneumo, example, PNU 10/29/13 and PNU 13/2/24/15?
So if the medical record is exactly like you have typed there, I would more than likely say the PNU 10/29/13 is the Pneumo 23, and because it says PNU 13, that's your Prevnar 13 was given 2/24/15. That's how I would read that example.
Okay, thank you for your question. And if anyone has questions, like we said earlier, we've got the Q&A, the chat, or if you would like to be unmuted to ask your question, you can raise your hand. And actually, I need to adjust my settings so I can see you all again now that I've got my screen share up. Deb, are you ready for the next resource?
Yep. So that's a pneumococcal. And like I said, at the end of this presentation, we will talk about the MDS coding because that, and explain how we're seeing lower than usual rates. So the last thing that I'm going to talk about right now is the COVID vaccines. So Kathy, if you could switch to the boost your rates protocol on the screen. There's been a lot of questions about what's considered up to date. And I know we all like decision trees. So this is a decision tree. Let me make my screen bigger here. Again, Kathy, if you could bring it down just a little bit that we could see just the decision tree part. Thank you. So this will help you determine if they are due for the bivalent or not, and if they're considered up to date. I did have a question posed to me this morning by a facility that stated if we had a resident come to our facility and they only had the first shot of their primary series, can we just give them the bivalent for their second shot of their primary series and consider them up to date? And the answer to that is no. At this moment, the primary series has to be given using the monovalent vaccines, and then 2 months later, the bivalent. So, I mean, there is talk that that's all going to change in the future, but at this point in time, the primary series is the bivalent. So you would just use this decision tree upon admission. Has the resident received their initial COVID-19 vaccination series? If yes, then have they received the vaccine? And if yes, then you just want to make sure that your medical record is up to date. If no, you're going to go through your education, your consent protocols, and all of that to see if they want the booster or they do not want the booster, providing all that education with the risk and benefits. If they have not received the primary series, then I'm not telling you anything you don't know. You know, you're going to go through your provider education, talk about the risks and benefits, offer them that primary series, which is the 2-part series. And then if they accept it, you know, you start the series. The timing is 3 to 8 weeks apart between the doses. If they decline the series, making sure that you have those consent forms and their reasoning for declining, providing them any additional education that they need. I think we've talked about being up to date with their COVID vaccine on quite a few calls recently, so I'm not going to belabor this topic too much, but we just wanted to share this decision tree. Everybody looks at things a little bit differently. So if this is something that will help you, Kathy's dropped the link for this resource in the chat, or you can reach out to any of us and we can ensure that you get that, and it's on our website as well. So does anyone have any questions regarding COVID and being up to date? Okay, so at this point then, I am going to turn it over to Christopher to talk about the flu vaccines, and then I will rejoin you and talk about MDS coding.
All right, thank you, Deb.
Yes, thank you, Deb. Go ahead and put up my first poster slide there. All right, everybody, I wanted to share this, excuse me, poster that we have developed here at Quality Insights. It is something that you can use at one of your facilities if you'd like to either use it as a handout and or just as a poster inside the facility to try and get the numbers of your vaccinations up. Please feel free to reach out to one of your Quality Insights specialists and they can get that to you. Go ahead and go to the next there. All right. Just a little background. I did do some checking this morning to get recent numbers for both West Virginia and Pennsylvania on flu. Thank goodness it's been fairly minimal here in West Virginia. There was only 312 cases reported in the most recent reporting in West Virginia. And then in Pennsylvania, it's considered more moderate. They didn't show a weekly list, but more of an overall season. So Pennsylvania's had 75 deaths already this year from influenza and over 172,500 cases. So they're a little bit more moderate than West Virginia is. So I just want to give you a little information on that in case you were wondering. Of course, with your patients or residents, you want to make sure you place them in a droplet precaution area in a single room if possible. If not, keep them in the facility in the area that they are already in their room. This particular slide that she's showing is the CDC guidelines for healthcare personnel safety reporting. That has changed as of just the end of last year. So reporting for healthcare personnel vaccination is required. You can go to the next slide if you'd like. We're going to share these website links with you. This particular one is just a breakdown of the earlier one you saw, and it specifically talks, I'm sorry, this is the toolkit. This particular toolkit does go over how to report and how to manage healthcare personnel and how to do that. The new guideline is, excuse me, that you are not required to do a weekly or monthly reporting in it's the healthcare personnel safety section of the NHSN, but it is required to be reported annually, and that due date is May 15th of this year. So you can report weekly or monthly if you'd like in the system. If you go in and report 1 month or 1 week, there's only one spot to report. So you would have to just add your numbers as to the total for the season in that section. But if you are going to just do the one-time annual reporting by May 15th, you go into the healthcare personal safety component of the NHSN. Like I said, that is a new change just for this year. And then we also, this long-term care toolkit will help you with that, with as far as determining the denominators that you also have to report in that reporting. And I believe we had one more slide, I believe. Yes, this is just a small portion of that first report we showed you from the CDC. It just basically outlines the new guidelines that came out in December that require you to do the reporting at least by May 15th if you're not doing the monthly reporting. Does anyone have any questions about any of the stuff I just discussed?
So we had one person who had a question right around the time you started talking. Says, so do you know how long someone can test positive for the flu? We admitted a resident from the hospital on January 10th who had tested positive for influenza at a hospital on December 30th, who was treated with Tamiflu and was there for 5 days. On January 31st, they went back to the hospital where they apparently tested positive for influenza A again. This would mean they acquired influenza A twice in a little over 3 weeks. I've never heard of this. We currently have only no other cases in the building.
Well, I did check. Influenza A is the more predominant strain this year that they're seeing. Usually someone can test positive, they say from 10 days to 14 days. So that is kind of rare. I would assume that was a reinfection of some sort. I'm not sure exposure-wise. But I'm not a medical director and I'm not an MD. I can't, personally speak to that. I've not seen that before, but traditionally 10 to 14 days is considered the timing that they would test positive.
Okay, and we have another question here. I report every week when I report my COVID report. I noticed this week that there is no flu vax icon.
So I can take that one, Christopher.
Go ahead.
Because of this reporting that has come out, and they didn't want to create, I can only hope that they were thinking they did not want to create extra work for the facilities. The NHSN reporting, where we were reporting weekly our flu immunizations for healthcare providers and our residents, had always been optional. But because they now want this reporting to go through the healthcare personnel safety component part of NHN, they did remove it from the NHN immunization under the COVID section. So you are correct that the influenza, those two categories under the immunizations did go away, and it went away in January.
We have another question here. Do you have to have a CLIA waiver in Pennsylvania to complete a rapid swab for influenza?
I'm going to say yes, because you have to have it to do the rapid COVID swab. You have to have it as a waiver as part of your CLIA license.
Okay, thanks, Deb. All right, so I think we're ready to move on to the next part. Did you have anything else, Christopher? Oh, wait, you're muted.
I'm sorry, I was just going to say if Deborah would like to go ahead and take over the coding portion, if there's no other questions.
Sure. So, well, Kathy's going to pull up a small PowerPoint that just has screenshots from the MDS. So we wanted to show you how and where does this information come from. So as we have frequently been talking, your COVID vaccination reporting is coming from your NHSN data. They get all that vaccination information from your weekly input into NHSN. But the influenza and the pneumococcal vaccination rates comes from your MDS coding. I have to admit, I'm quite surprised considering there are MDS updates coming out in October that the COVID vaccination status is not being asked in addition to the flu and pneumo. I mean, there's still time, but I am surprised that that's not there yet, but it's not. So at this point, it's just the flu and pneumo vaccination that's being coded on the MDS. So in looking at the MDS code, Kathy, if you can go to the next slide. So here is your pneumococcal vaccination coding. This is just a screenshot of what the MDS looks like. And then we pulled out the RAI definitions. So the first question is the resident's pneumococcal vaccination up to date? So it's a simple yes or no. And what we are seeing is a couple things. RNACs that are aware of the new pneumococcal guidelines, if they don't have a clear understanding of what the guidelines are, or if they know that the resident has not received both the Prevnar 13 and the Pneumo 23, and they haven't received the Prevnar 15 or 20, they could now be coding this as no, they are not to date. So you could have gone from 100% up to date, and all of a sudden you're now at 50%. So that's where this up to date really comes in, that not only you that are on the call understands what the new guidance for being up to date, but making sure how does your RNAC understand that coding to be, and how are they coding the MDS in regards to being up to date. And if they're not up to date, or if they have received the vaccine, are they not eligible due to a medical contradiction? Have they offered and declined, or have they not been offered? So just to make sure that everyone understands what those definitions are, not eligible is usually typically due to a medical contradiction that's, a life-threatening allergic reaction, or a physician said not to give them at this time because they're too medically compromised for whatever reason to receive a vaccine. Offered and declined is you have explained the risks and benefits, you have your consents in place, and they have chose to decline the vaccine. And coding 3, that's where your percentage can really come down all of a sudden, is you didn't offer the vaccine. So when they're looking at your quality measure, and they're looking at the pneumococcal rate, they take into consideration, was the vaccine administered? Did you provide the education and the resident declined? Or is the resident not eligible? If any of those 3 are coded, it does go into your percentage. So in some aspects, to us, to you as the facility, it's almost, in my opinion, it's a skewed number. So if you have 100 residents and you have 50 that accepted the vaccine and they're up to date, and you had 50 that you did all the education, you have your consent, and you offered and they declined, you have 50-50. In your eyes, you're like, okay, 50% of my residents have had the pneumococcal vaccine, but because those other 50 offered and declined, that is counted into it, and your quality measure rate is going to look like you have 100%, because you've addressed their vaccination status, they are up to date, or they're not eligible and they are declined. So that's why it's really important to get that history and make sure they're up to if they want to be up to date. So Kathy, you can go to influenza. Influenza is basically same coding. Did they receive the flu vaccine during the current flu season? So between October 1st and March 31st, did they receive the vaccine? Now, the first one is going to be yes, if they've received it in your facility, and then you'll put the date that received in your facility. But then you have options to say, yes, they received it, but they received it outside of this facility. It's better to code number 2 in C that they received it outside of the facility than it is to say resident not in this facility and not address what their vaccination status is. You want to make every effort to get vaccination history when the flu vaccine time period is over and the resident's been admitted. So if you have an admission in June, you're like, well, it's not flu season. I don't care what their flu vaccine was because I don't have to give it anymore. We're done giving it. That's true in that aspect. But if you want to make sure you have a good percentage of completion of the influenza vaccine, you want to get that history so you can account for were they vaccinated during the time period, and then you would code that they received it outside of the facility. And again, the same thing that we talked about, the pneumococcal, you want to address it as much as possible. Did they receive it? Did they offer and decline it? Or are they not eligible due to a medical contradiction? So another error that I see is it's June, so they're not eligible because it's June and it's not during the influenza vaccine time period. Not eligible is only related to a medical contradiction. So I know we're running out of time, but does anybody have any questions regarding the understanding of the MDS coding process and how that affects your rate?
So we don't have any MDS questions yet. If anybody has those, they can drop them in. We've got a couple questions from people who said they missed the beginning of the webinar. Not sure if we covered these 2 questions, but you can bring us up to speed. One asks, what is up to date, or where would I find that answer? And I believe, what would they be talking about? Up to date on the COVID vaccine, or would it be a different vaccine?
Yes, it would be COVID.
Okay.
Do you want to take that, Deb, or?
I'm trying to find the question. I didn't quite hear the question.
She wanted
Sorry.
to know where to find the definition for up to date now on COVID.
So there's a number of places you can find it. You can just Google what is considered up to date. Also, if you are in NHSN and you're in the NHSN reporting, right where that question is, where it asks how many residents are up to date, there's a hyperlink and you can click on that, and that will also take you directly to the CDC site of what is considered up to date.
Okay, and our other question was, it says, I wasn't able to see where to report new influenza vaccine report.
Okay. I'll take that. That was one of the links that we posted in the chat. It is under the healthcare personal safety section in NHSN. We looked this morning, and as of now, it still was not in there. Like I said, the policy just came out a month ago, or was revised a month ago. So I'm hoping at some point in time, they're going to correct that in the NHSN. Not that one, Kathy. One of the other ones there. Yeah. So right there gives you the instructions on how, where you're supposed to do that. And the other one is just a simple template that gives you the new rule on the, that's the long-term care, the other one. There you go. The 1-page piece should be operational, maybe. There you go. The operational guidelines as to the new mandate. We'll send that out, and like I said, in the chat box, but as of now, even though they have this out as the mandate, I don't think they have it fixed properly in NHSN yet. But that is the goal, the instructions we've been given us to tell you what to do. I apologize for that. You know how well the government works.
So I see a couple questions in there that may be directed towards me. For MDS purposes, what time period is this year's influenza vaccine season? I have always used October 1st to April 1st. That's correct. It's April 1st to March 31st. So that is the flu season that they look at for MD purposes. And then you have through June to capture any MDS that's done up until June will capture their influenza vaccination. So say you had a resident admit on March 30th and they didn't have their vaccine and you offered it and you give it March 31st, because you have 90 days to complete an MDS or their first quarterly. So I'm going to back that up a little bit, but you have until June for an MDS to capture their influenza vaccination history for that year's influenza vaccination season. Hope that made sense.
Then someone
and
else
then I
clarified
think-
that they wanted to, their question was about being up to date on pneumonia, and someone else also asked in the Q&A, what is considered up to date with pneumonia? Do you want me to pull the
Okay.
decision tree back up?
Yeah, that'd be great. So up to date with pneumonia is a couple different things. First, if they've had no vaccination history at all, want to offer and administer the Prevnar 20. If once they have that Prevnar 20, they are up to date. Now, if your medical director says, you know what, I don't want to do Prevnar 20, I want us to do Prevnar 15. Or maybe your pharmacy can only get Prevnar 15 and not the 20. If you do the Prevnar 15, if they've had no vaccination history for pneumonia, and you give the Prevnar 15, they are considered up to date until you hit 12 months later. It's kind of just like the COVID. Once you hit that magical time frame, once they hit 12 months later, now they're due for a Pneumo 23 vaccination. Until you would give that Pneumo 23, they would then be considered not up to date until you would give that Pneumo 23. Once you do that, then they're again considered up to date. If you have an admission and they have had the pneumonia 23, you would want to find out when did they have that. And then 12 months later, they are due then for either a Prevnar 15 or a Prevnar 20, and then they would be considered up to date. If they've had either the Prevnar 13 or the Prevnar 23, then 12 months later, they are due for the opposite of what they had first. So basically, if you look at this decision, if you take any of the dark blue arrows, you follow it to the light blue arrow. Once you hit that end of the light blue arrow, you're done, and they are considered up to date. And if you haven't hit the time frame for the second blue arrow, they are still considered up to date until that time period comes due that they would be due for the second blue arrow. Does that make better sense of how to use this decision tree and what's considered? There's so many different variations for the pneumococcal vaccine, and it all starts with what was their history, what have they had up to this point, and then you kind of follow the tree to the right to determine what they need after that. I could tell a story. I know the facility's on the call and I won't call them out, but they were really trying to work on this and get their residents up to date. And we were on the phone and they would be like, well, what about this person? They've had this and they've had that, and they'd give the dates, and we would really talk through it. And all of a sudden everybody started laughing and they're like, okay, we got it now. Like, you just have to work through a couple of them to determine, till you can figure out, because there's just so many different variations of when someone received what type of pneumo vaccine and what did they get and when did they get it and how old were they. And so there's a lot of different variations. Let me see if there's any other questions we missed here.
I think there was one about the flu that I was keeping an eye on, but I think I lost track of it.
So if it's out of the flu season or admitted, which should we choose? Amy, do you mean on the MDS? So if you mean, how do you code the MDS? If it is out of the flu season, you still want to find out, did they receive the influenza vaccine in the community during the prior flu season? So going back to the fact that they were, even if they were in April, so you stop giving the flu vaccine March 31st and say they were admitted April 2nd, you still want to find out, did they receive the flu vaccine anytime between October and March 31st? And then code that they received it outside of the facility. Now, I had an interesting question, Kathy, if it's not too much trouble, if you pull up the PowerPoint with the influenza coding. I had an interesting question posed to me, and I know how I would have coded it as an MDS, and I can really look at the manual more if somebody really wants to get more specific with this. But some medical directors will say, you can start giving the influenza vaccine in September. So how do you code the MDS for that? So if you gave it in the facility, quite frankly, I can tell you, I have always coded, yes, they received it, and I would have put 9/12/2022. It would be interesting to see how that would have affected my QM report. I can tell you that's how I've coded it, but I can certainly, that question was just posed to me today. So if we really want to look at that, I'll research that more in depth and have that on our next open session of a Q&A that we're planning for, I believe it's mid-February, and I can have that information for you. So hopefully that answered Amy's question.
I think that's it for questions for right now. I'm going to do some wrap-up show notes, and in the meantime, if anybody else has any questions left, please put them in the chat, the Q&A, or use the tool to raise your hand if you would like to ask your question out loud. Okay, so if you have any, excuse me. So while we're waiting, I'd again like to invite everyone to next week's webinar. We'll be discussing bivalent COVID-19 vaccine and stroke risk next Wednesday at 2 p.m. And again, I'd like to invite everyone to our webinar on Tuesday at 2 p.m. With our medical director, Dr. Jean Storm, where she'll be presenting on navigating opioid prescribing through 4 different healthcare environments. And this is the webinar that will be eligible for CE credits. And I'll drop the links for that event and the flyer promoting that event in the chat again, if anyone missed that at the beginning of our webinar. If you want to have a one-on-one discussion with our quality improvement specialists, we invite you to join us during our virtual live chats, and we will be changing the time and the venue of those live chats starting next week. Beginning on January 31st, we'll be hosting them in Zoom. They will be noon each Tuesday and Thursday. And you'll be able to find the links to those live chats and our webinars in our newsletter that we send out each Friday called the Last Minute Lowdown. If you would like to receive that newsletter but don't think you're on the mailing list yet, you can email me at caudill@qualityinsights.org and I will get you on the list. And shortly, I will be dropping into the chat my email, Deborah's email, Christopher Henry's email, along with that webinar information. And I just wanted to add that I will be sending an email later this week with the recording to this webinar and all of these resources links later on this week. So if you missed opening anything and you wanted to open or download, I will be sending that probably on Friday. Okay, we got a couple more questions that just came in.
Yeah.
So
we realized that I was going to say, we realize the time for this is over. So if there's people that want to hop off, you can. Kathy, are we able to stay on a little bit longer for questions if they?
Yeah, we're not completely at our limit just yet if people do want to stay on.
Okay, so the first question is, if a resident was admitted in June and did not have the influenza vaccine during the last flu, season? Do you keep them as up to date until you can give it in September or October? In that scenario, if you vetted it out and you truly found out that they did not receive the vaccine, that is when I probably would code in C number 2, or I'm sorry, number 1, resident not in this facility during this year's influenza vaccine season, because that way you are still answering the question, you vetted out, they didn't have it. You can't really say, you're going to say no, that they didn't receive it in your facility for question A. Then when you get to question C, the really the best option is they weren't in your building because they didn't receive it elsewhere. They weren't medically contradicted. You could say offer declined, but that's more, they were in your building, you offered it and they declined it. So I would code that scenario as resident not in this facility during the year's influenza vaccination season. And then the next question is I just lost it, where'd it go?
If a resident has 2 P23 vaccines, would they need a PCV13?
A resident has 2, I have to, hold on a second, I pull the tree up. I think they would. Oh, there you go. So my guess is they've had 2 of the 23s based on their age of their first one. So if they had the 23 and then they had the 23 again 12 months later, then I would take the arrows back and I would, they would be eligible for, let me see here, they had the 23. They would be eligible for the 15, the 20, 12 months after their last 23. So the Prevnar 13, nobody should be giving anymore. So the Prevnar 13 is kind of off the table. It's a matter of, are they due at this point for the Prevnar 15 or 20? And I would say yes, that they are. So they would 12 months after their last Pneumo 23, they would be due for either the 15 or the 20.
Thanks, Deb. And then we have one more question that Patty dropped in. She says, so here is my RNAC question. Is that how you say it, RNAC?
Yeah.
Here's my RNAC question. Went round and round with this in my RNAC days. Beginning of October, say first 2 weeks. Unless you can schedule your clinic for October 1st, then any MDS will reflect a not offered.
So yes, that is correct. It will reflect a not offered, but they look at the influenza QM all the way up until June. So you have until a June MDS to capture your influenza administration and not have it affect your quality measure. So if you did your MDS on October 1st and you didn't get your vaccine until October 14th, October to November, December, January, when you do your January MDS, you will then have captured that influenza vaccine and you're good to go.
Okay, thanks, Deborah. And for anyone watching a recorded version of this later, all the links that we've discussed today will be in the show notes, whether that's on the podcast or on our YouTube channel. And I think we're ready to wrap up here. So again, if anyone has any.
Can I just say one more thing, Kathy?
Sure.
I know that there were a lot of questions. We are planning on having an open Q&A, like I said, in the middle of February. So if you have any other examples that you want to work through, you can feel free to give me a call in the meantime, or send your questions over and we can make sure that we have the answers for you during that live Q&A.
That's perfect. Thanks, Deborah. And Christopher, did you have anything to add before we sign off here?
No, I just wanted to thank everybody for attending today.
Okay, thank you. Oh, yes, thank everybody for coming today. Deborah, Christopher, thank you both for joining us today. And we hope to see you all back next week.